Welcome to Science Force, where science comes alive. A very warm welcome to all of you joining us for today's explainer. I'm absolutely thrilled to have you here because today we're diving into a fascinating yet deeply serious medical mystery. We are investigating a notorious culprit that operates completely in the shadows. Whether you're just curious about how your own body works, or perhaps you're a medical student deeply immersed in your life science studies, this beautifully colorful explainer is designed exactly for you. We're going to break down the whole shebang, the science, the symptoms, and the solutions to literally one of the stealthiest conditions known to medicine. The silent thief of sight. The nickname itself is honestly a bit chilling, right? The silent thief of sight. You see, most medical emergencies, they announce themselves. A broken bone brings sharp pain and infection gives you a fever. But this thief, it is terrifyingly quiet. It steals your vision incredibly slowly with absolutely no early pain and frankly no early warning signs. By the time a patient actually notices that something is missing from their field of view, well, the thief has already made away with a huge portion of their sight. It perfectly bridges the gap between the layman's metaphor and a very harsh clinical reality. And just look at the sheer scale of this crime. 80 million. That is the number of victims globally. Glaucoma affects more than 80 million people worldwide, making it the second leading cause of blindness on the entire planet. But the absolute most crucial detail here, the thing that really raises the stakes for every single one of us, is that the vision lost to this thief is completely irreversible. Once it's gone, it is gone forever. No way to get it back. So here's our brightly colored roadmap to catch this thief. Anatomy and mechanism, types of glaucoma, risks and symptoms, diagnosing the damage, treatment and prevention. Number 1, anatomy and mechanism, the scene of the crime. Let's jump right into the eye itself. For our students tuning in, here's your clinical definition. Glaucoma is a chronic eye disorder characterized by progressive damage to the optic nerve. Now you might be wondering, why is the optic nerve so incredibly important? Well, imagine it as a high-speed broadband cable connecting your eye directly to your brain. This single nerve contains over 1 million distinct nerve fibers. They transmit every beautiful thing you see straight to your visual cortex. And when these fibers are damaged, exactly then is when those blind spots begin to develop. Aqueous humor flow. To really understand how that broadband cable gets damaged, we have to look at the plumbing. For our general viewers, just think of your eye like a sink. You've got a tap that's always running and a drain that's always open. The tap is the ciliary body, which constantly produces a clear fluid. Now, for our life science students, do take note of the clinical term here. This fluid is the aqueous humor. It beautifully nourishes the cornea and the lens. Once its job is done, it drains out through the trabecular meshwork and into Schlem's canal. In a healthy eye, it's a perfect continuous flow. The pathophysiology. But what happens when the sink stops draining? In a healthy, normal eye, fluid production equals fluid drainage. The pressure inside your eye, which we call the intraocular pressure or IOP, remains perfectly stable. But in a glaucomatous eye, that drainage system is compromised. Fluid production is suddenly way greater than fluid drainage. The tap is running, but the drain is clogged. And as that fluid builds up, the pressure inside the eye starts to rise to dangerous levels. So the crucial point is how that pressure actually turns into blindness. We call this the pathophysiological cascade. The increased intraocular pressure, or IOP, physically presses down at the back of the eye. This causes compression of those 1 million delicate optic nerve fibers we just talked about. And because they're compressed, the blood supply to the optic nerve is choked off. Starved of oxygen and vital nutrients, we start to see progressive nerve damage. Ultimately, it results in retinal ganglion cell death. And once those specific cells die, the vision is permanently lost. So here's our brightly colored roadmap to catch this thief. Primary open-angle glaucoma, POAG. This is your classic silent thief. The drainage angle is technically open, but the trabecular meshwork is just incredibly inefficient. It's slow, it's painless, and by far the most common. Angle closure glaucoma. Contrast that entirely with angle closure glaucoma. Here, the iris physically blocks the drain. Listen closely. This is an acute medical emergency. It causes severe eye pain, terrible headaches, red eye, and you'll even see halos around lights. If not treated immediately, blindness can happen in just hours. Normal Kenshin glaucoma. Damage occurs despite totally normal eye pressure, likely linked to poor vascular blood flow. Congenital glaucoma, present right at birth. Babies present with enlarged eyes and excessive tearing. Secondary glaucoma, which is essentially an inside job driven by other conditions like eye injuries, tumors, or even long-term steroid use. Risks and symptoms. Tracking progression. Not everyone is equally at risk, you see. Certain factors essentially leave the front door wide open for this thief. Age is a huge one. Risk rises after 40 and really spikes significantly after 60. Family history plays a huge role too. Genetics definitely matter here. Furthermore, systemic medical conditions like diabetes mellitus, hypertension, and cardiovascular disease make that optic nerve much more vulnerable. Even structural eye conditions like severe myopia, that's nearsightedness, or having a thin cornea, or taking long-term steroid medications can dramatically elevate your risk profile. Symptom timeline. The chilling timeline of this disease begins in the early stage with absolutely no symptoms, completely normal central vision. The patient feels completely fine. But as the disease progresses, the edges of your vision begin to slowly fade. You experience peripheral vision loss. You might find yourself frequently bumping into objects or suddenly having difficulty driving at night. By the advanced stage, the patient is left with tunnel vision, literally like looking through a very narrow straw, which eventually collapses into near or complete blindness. 4. Diagnosing the damage, the investigation. Let's see how the doctors do their detective work. For our medical students, do pay close attention to these clinical diagnostic tools. Tonometry, used to measure the intraocular pressure. A normal reading is about 10 to 21 millimeters of mercury. Ophthalmoscopy. This allows us to look directly at the optic nerve. We are specifically looking for what's called optic disc cupping and any nerve fiber loss. Visual field testing to map out that early peripheral loss. OCT. For incredible, almost unbelievable structural detail, we use OCT to image the retinal nerve fiber layer itself. Gonioscopy, using a very special lens to evaluate the drainage angle and properly determine if it's open or closed. 5. Treatment and prevention, stopping the crime. Our treatment strategy essentially operates like an escalator, moving from the least invasive to the most invasive options, all with one singular aggressive goal: lower the eye pressure. Step 1 usually involves prescribed eye drops to lower the IOP medicinally. Step 2, if that's just not enough, we escalate to Step 2, laser therapy. Procedures like a laser trabeculoplasty help clear the drain in open-angle cases, while a laser iridotomy creates a tiny hole in the iris for those emergency angle closure cases. Step 3, when medications and lasers both fail, we reach Step 3, surgery. We can surgically create new drainage channels through a trabeculectomy or use minimally invasive glaucoma surgery, also known as MIGS. Now, this builds a really solid pharmacological foundation. For the life science and medical students, here's a rapid structured clinical review of those Step 1 eye drops. Prostaglandin analogs, like letanoprost, work by increasing fluid drainage. Essentially, they're widening the pipes. Beta blockers, such as timolol, take the exact opposite approach. They reduce fluid production, effectively turning down the tap. Carbonic anhydrase inhibitors like dorzolamide actively decrease the formation of that aqueous humor. By carefully combining these mechanisms, we can effectively manage the pressure. But as we've learned today, we actually cannot restore lost vision. Therefore, prevention is ultimately our weapon. The preventive action plan is simple but vital. Regular eye examinations are completely non-negotiable. They are quite literally the only way to catch the thief early. We must continuously monitor eye pressure, strictly control underlying systemic conditions like diabetes and hypertension, and if diagnosed, you must use those prescribed eye drops consistently, without fail. Throw in some protective eyewear during sports to prevent any secondary glaucoma, and you are building a formidable fortress around your sight. So I want to leave you with a single powerful question to think about. Are you protecting your sight from the silent thief? Because understanding the anatomy, recognizing the risks, and knowing all these diagnostic tools, it's all meaningless if we don't take proactive action. Don't wait for your vision to fade, please. Schedule that routine eye exam, protect those 1 million delicate nerve fibers, and keep your world vibrant and clear. Thank you so much for joining me on this explainer, and as always, keep learning. Thank you for watching Science Force.